welcome again to our next small baby Q&A. And if you've taken the course, you recognize both of these amazing women, Jane Solomon and Katie Fedor, who are colleagues at St. Joe's Women's Hospital in Tampa, Florida. And we have we have them to blame or them to thank for creating the small baby course I think it was during the pandemic, and Jane said, we really have this program we want to roll out and we need some help creating the content, and it just mushroomed and ballooned from there as a small little idea into what it is today. And we're so grateful to them, to their team, for just their constant feedback about the program, and also just their constant contribution to this community, and to just continuing to share their journey so transparently, the good, the bad, the ugly, the ups, the downs. But I think it's mostly success. But they have really implemented some amazing checks along the way, a new program that they're doing. And so I know you're going to really enjoy being able to hear their journey. And we did this presentation about a year ago, so it's another yearish since then. And they're about 18 months in now, right, in their formal small baby program. Is that right, Jane? You're not.
Yep.
And also, I'll let Jane introduce Katie, because Katie, in her role for this project and the unit, is incredible. And I know Jane knows all of what she does, but the little that I know about Katie, she is one of the most tender-hearted, caring, hardworking, dedicated NICU nurses you will ever have the privilege to meet. She's an amazing writer, if you ever see any of her blog posts or her Instagram posts, but we're lucky to have her with us as well today. And I think we even have another colleague from their team, one of their neonatologists, who also might be hopping on. So you may have a triple threat today from the whole team at St. Joe's. So again, welcome to the two of you. Thank you for being here, for all you do for me, for Synapse, for babies. And we'll just let you take it from there. So Jane?
Yep.
You want to give a little, do you want to do a little couple? Okay, great.
Yep. Good morning, everybody. I'm Jane, as Kathy introduced. We're here at St. Joseph's Women's Hospital. It's a level 4 NICU in Tampa, Florida. We have up to 76 beds. And just for a timeline, so you guys know that how early we are in the program and how long it took to even get to where we are. In 2020, we kind of had the vision for the small baby program. We had a very, and still do, very successful cooling program. And we were looking at that and wanted to take pieces of that to apply it to a small baby program. So in 2021, we were kind of putting the small baby program together. We had a lot of behind the scenes meetings to look at all the different aspects and different disciplines that would be part of it. So there was almost one full year of planning before we even implemented it. In case anybody's thinking, well, I'll just start a small baby program. There's a lot to it. And, it's almost a year, like I said, for us getting started. And then in 2021, the first half of 2021, we kind of were collecting our baseline data and trying to figure out what metrics we really wanted to look at, and making sure that our audit tools, or the parts of our small baby binder that you may have seen, reflect the metrics that we were looking at and trying to achieve. So going back in time and looking through charts, that we knew exactly the goals we wanted to achieve, and we had tools that we would be measuring them in real time. So we actually started implementing the program in the fall of 2021, and this will be our full year coming up now. And we have made so many changes along the way. You can't imagine how many times you can edit a PDF, but they've all been good. And I think we're very lucky at St. Joe's, because we have such great, not only neonatology engagement, but team member nursing engagement. And my partner here is Katie Fedor. All I can say about Katie is every unit needs a Katie, for sure. She's my right-hand man. She's such a strong clinician. She is able to read what's going on in the unit, when a good time for a rollout is. She brings just tremendous perspective and leadership. So definitely couldn't do it without her. And then also a shout out to Kathy, because when I told her we needed something like this, she's always game for meeting the needs of units around the country. So it definitely wouldn't have gotten this far or this kind of attention if it wasn't for Synapse. And that's what we want. We want to share what we do. We want to hear about your small baby program, because that's really how we learn, and not everyone's spending a ton of time doing something that someone else has already done.
Yeah, absolutely. I feel like so much of it was just really gaining insight from other people, and just trying to build from some of the things that we learned from people going through the process already. So, and I just have to, while we're shouting out people, just give a major shout out to Jane too, because she's kind of brought me along. I think, we all go into the NICU because we have passion for the NICU, and it's an easy part of healthcare to be super, super passionate about. And you just have to have someone who constantly sort of reignites your passion, because especially in the last couple of years, it's been hard to get a little beaten down by just life and things that go on in the healthcare system, and just trying to battle the pandemic and all of that. So you needed to find the Jane in your unit who will just kind of press you to keep going, and keep reminding you why you got into this field. And we're really starting to feel the upswing from, our coworkers, and trying to get back into projects and things like that, because that's what really keeps us going, in a passion sense. And Jane is that person for us. So just a huge shout out to her. And I'm super excited to hear about all of your programs and soon to be programs, hopefully. And we'll be very honest about sharing the things that we've learned. Like Jane said, the edit feature has been our biggest tool. So we've edited things. I think I stopped tracking what version we're on a long time ago, but feedback and edit has been the key. So we're excited to share with you what we've learned so far.
So we've already introduced ourselves. This is the latest portion of a slide set that we recently just sent out to the team, literally about 3 weeks ago. So this is hot off the press, and this is where we are now. We actually named the slide "Emphasizing Intentional and Expeditious Care of the Small Baby," because we wanted, one of the big focuses that we noticed is people really, really need to know their roles, and we need to be able to do them quickly but with efficiency. And I can share a couple of stories of how we got there. So next slide. So here, this has been the analogy that I've used, and it's worked very well for us in our unit, which I know many of you, if you're doing small baby, understand the analogy with the Rubik's Cube. This is on your cube all the way to the left is the perfect cube. That's everything's done. It's 100% perfect. And that's how we imagine the baby is in utero. Temperature's perfect, respiratory is perfect. Everything that baby needs is 100% lined up. Metrics are perfect. Within 20 seconds after the baby is born, you have the next cube. Everything becomes scrambled. Your temperature has completely changed. The way that you're going to breathe has changed. And so over the course of time, in that golden hour and through the rest of the baby's life, but particularly in the first 21 days, what we're trying to do is get the cube back to all the matching colors. And that has been the premise of our small baby program, is how do we tweak it so that as we adjust temperature, we are not doing something detrimental to the respiratory aspect of what's going on with the baby. Or if we change a nutrition, is that going to affect respiratory? And that if you're increasing feeds today, are you going to have to give up on weaning your O2? So what we wanted was people to think about every little thing that you do and the relationship with health, with baby systems among each of those different areas. And that's how our care plans are set up. And then the third picture over is what happens when you're not prepared. Everything just goes terrible. And I'm sure many of you have had that, and it's very hard to put a cube like that back together. We also have this picture of the brain down here, and this is one that we show often in our small baby class, just to let people know what's happening on our watch through the first 21 days and up to term on these babies. Especially if you look at the 24-weeker, we basically have no sacri, gyri, no folding, no growth. And it's just a huge reminder that everything that we do to this baby is going to mold that brain. And I think it's just very sobering to remember that. Next slide. So these are our lessons at 18 months that I was just going to quickly go over with everybody. First of all, we learned that we need to audit in real time. So as you know, if I would collect the binders at 3 weeks, because our small baby care plans go from birth, golden hour, through the first 21 days. If I picked them up at like 6 weeks and just started looking at them, like everything else, it's kind of hard to go back in time and think, why didn't this work out? Or why was there a problem here? Or the nurses are really good about writing comments in about how they would like change. So very important, if you can, look at things in real time. The other thing we learned was just practice, practice, practice. Our most recent small baby class, really our whole emphasis was on mock admissions. And I know everybody knows how to admit a small baby. We do it all the time. But if you actually really stand back and look, there's a lot of miscellaneous stuff going on in the room that you don't need. For us, one of the things we noticed was number of people in the room, a number of people trying to do the same thing, and the loudness in the room, because people are calling out to each other. Hey, did you get this? Can you get this for me? It felt a bit chaotic instead of a very controlled environment monitoring noise levels. So for this part, our neonatologist actually came up with the term baby bouncer, and she served as our baby bouncer where she's kind of standing outside the admit room. And if you don't have a role in the admission, then you get bounced out of the room. We can definitely give you errands and things to go get, but we really, really tweaked it and became very serious about how many people could be in the room and what their role was, which leads to role definition and clarification. Because I know you guys all know, like everybody is a team player, and when you get a baby, everybody wants to run in and help and check, but it doesn't really help if nobody really knows what each person is doing. The other thing we learned about, which was huge, was the value of the scribe. So for us, when we admit a small baby, we have the admitting nurse that's actually doing the hands-on care and admitting the baby. And then we have a scribe, or what we call the writer, who's entering the baby in the computer and doing all the charting. So that's getting done in real time. But we assigned some other values to the scribe, which I have in another slide, to kind of be the air traffic controller of the room. That we're looking at this, they're not just kind of like checked out and charting and you call out a temp and they write it down, but they're actually supposed to be surveying the entire room to see what's going on, including number of people, noise level, light level, did somebody do something with dad? And just recently, making sure, like the challenge that we all have is that the temp probe is on, it's secure, and the baby's on servo. So we've adjusted our admit checklist to reflect some timeout periods to just double check and make sure that we are moving through the golden hour, but the things that we've done prior to that first 15 minutes are still going well. And then the last thing, which I would really like to thank Dr. Eldridge for, if she's on, is the debrief in real time. Even if you can only do it for 10 minutes, 5 minutes, whatever, just very quickly at the end of the golden hour for the people that were involved to quickly say what went well, what we could have done differently. And honestly, Katie, when you say we've learned so much from the last 3 debriefs, I think that's where we've made some major changes.
Yeah, absolutely. It's given us a chance to just kind of adjust things in real time and get a lot quicker about getting the feedback and turning it over into something valuable.
And that also, when you ask the people in the group, the small baby team, when we do the debrief, I think it just brings a sense of teamwork and camaraderie, because at one time, you know, you're hearing from the neonatologist, hey, great job, that went well. And it's kind of like a mini team building sort of exercise. And at the same time, it allows a small baby team to feel like they can contribute to what these care plans look like, that people aren't just handing that to them. We can go over the rationale for why we do the things we do. And, you know, in theory and on paper, a lot of things seem like a good idea, but then when you roll them out, you find all the kinks to it, you know, equipment problems, or that day we didn't have a dedicated small baby nurse, or the NEO wasn't available, so the NMP came in. And how do we navigate? Because you don't always get that perfect situation. And then the newest thing that we've done lately is having our PIC nurses trained, we have a dedicated PIC team. So having our PIC nurses trained to set up the UAC tray, we realized that was taking quite a bit of time to get set up, and the NEO was kind of standing around waiting for that. So we are currently in the process of checking off our PIC team. So the entire line tray is set up and ready to go when the neonatologist or practitioner come upstairs. And then lastly, something that we're doing with placental cultures, and I can show you a couple of slides on that as we move forward. So next slide.
Yeah, Jane, just so you know, Dr. Eldridge arrived, so I don't know if you want to ask her to add any details to the debrief. She is here.
Yes. Hi, Dr. Eldridge. You are amazing. You're always, so engaged in helping us move this along. Dr. Eldridge just recently became our associate medical director and is hit the ground running, getting engaged in a lot of the projects that we're doing. And a lot of the line tray setup was her idea, as well as getting some Cervanta ready. So please, Dr. Eldridge, if you can unmute, love for you to say a few things.
Oh yeah, hi. I missed. I'm sorry. I'm on service, so I'm getting through some patients. But yeah, no. Jane and Katie have done awesome with getting things organized and motivating the team, and we've just found that the more communication, the better.
Awesome, thank you. All right, Jane. Next slide.
Okay, so this is something, this was, I know everybody here, I would think, has seen Top Gun. So we're always trying to kind of bring a creative edge to what we ask our team to do. And for our recent small baby classes, we kind of took the theme of like the Top Gun thing, which is, teamwork, people working together, what it's like to try to be on a mission that sounds like it's impossible. So that is why this one says the small baby pre-flight checklist. These are all the, and I know it's, I can share this with anyone. I know it's a lot to read right now, but this actually came from some of our audits and just standing back and watching an admission and realizing that people really still didn't honestly know their specific role. So we wrote it out very specifically, what needs to happen in an ideal situation before the baby's even born. So you can see what the charge nurse's job is, what the admitting nurse's job is, etc. And we did something really cute. We did a kind of a video of what it's like to kind of mirror the Top Gun thing. I don't know if you guys have seen it, but where he says to make this happen, we're going to need 3 miracles. So we kind of talked about the 3 miracles that we would need, which was getting downstairs and getting the baby upstairs with a good temperature, best respiratory status that we could. Second miracle, getting through the golden hour and meeting all our metrics there. And then third miracle, getting to day 7 with a good head and having met the metrics. So we did a small video of one of our neonatologists kind of doing a spoof on Tom Cruise and how he was talking about that. But this has been very helpful, and this is given before the baby's born to each of these people so they can review their role. Next slide.
Yeah, awesome. Can I just point something out real quick too yes. On that? So I think it's important to note as well, none of the things on this checklist were really new processes. It was really just a gathering of things we kind of did automatically already. We just kind of wanted to put them in one place. We started with, we have an admission checklist for our whole unit, and then we created a separate admission checklist for the small baby. And then we realized, okay, well, we have that, but now we really need another checklist for how to prepare for even the admission of a small baby when you have the luxury of time. Not all babies come up or are well known to be coming before they get there. But if we know about an impending admission of a small baby, we can initiate all these steps. And we have a lot of role changes in our unit, a lot of people that are new to the charge role. And so this kind of helped remind people, these are your sort of duties, and trying to make sure we're pulling in pharmacy and radiology, and even our secretaries. We've had them send out a text to the whole unit on our patient safe phones just saying, hey, we're getting a small baby. Can you give the NEO, the charge nurse, hold all calls that aren't emergent for the first 60 to 90 minutes of life. Even things like that have been super helpful. So, but most of this checklist are not new processes. It was just sort of gathering and placing value on those things that we do automatically and just making sure they're being done consistently.
Before we move on, I guess I was just say this is really incredible, and I wanted to ask the audience and those here, do you guys have any questions about this? Are you doing anything similar? I feel like this could be a real game changer, and I love the Top Gun analogy that you guys have done. So if you want to unmute, maybe raise your hand. We can call on you or put a Q in the chat, and I can call you out if you're in a place. Anybody have any specific questions about this or doing something similar, and maybe you have a suggestion for Jane and Katie to make this even better? Don't be shy. No, you're good. All right. I'll give you guys a second.
Yeah, if we have time at the end, I don't know if Katie has it, but we can show you our quick spoof on Top Gun. I don't know if you have the video, Katie, but we can show it at the end because it's really funny. It's just like a 2-minute video, but it's like you kind of need things like that, to try to get to make your team smile and be engaged. And honestly, now people, when we hand them the small baby pre-flight checklist, they get it. They associate that with the video, and we've even had a couple of our RTs ask for call signs. So
nice, just to keep it quiet, huh?
Well, they want their own, like Maverick.
And, they want their own name. Got it.
Yes.
Got it.
Yes.
Did somebody unmute, or Dr. Eldridge, do you have anything you wanted to add?
Oh, sorry. No, I was,
okay.
I'm multitasking and
no worries.
No, I don't have anything to add. No.
No worries at all. All right. Okay. Next slide. Yep. There you go.
It looks like there was a suggestion in the chat for role identification lanyards. I really like that suggestion.
Yeah, that's a great idea. Love that. Is someone actually doing that, or you mean having it on a small card that's part of your badge? I'll keep going, Kathy.
Heather, do you want to unmute?
Oh, okay.
It looks like they have them.
Oh, nice.
Hi, yes. Can you guys hear me okay?
Yeah, you sound great.
So yes, we use role identification for admissions in our NICU here at, in St. Louis, Missouri. And we really identified very similar to what your team has identified 5 key roles. So that way we wanted to wear them on our person because, as you guys know, in the NICU, sometimes you have to, we try not to swap out a role during, especially whoever's documenting, or I think you guys call it the scribe, but whoever's documenting, we try to keep that consistent. But there are times where you might have to switch out with another nurse. And so that way you can take your lanyard and actually hand that over to that nurse. So then they are identified in that role that they've transitioned to. And then we wanted to incorporate our family really into this process too. So we do have a role that is just a family support role. So that way, perhaps the admission nurse and obviously the documenter, they're focused on their important tasks that they need to complete within that golden hour. But then we have that designated role who is updating that support person that's came with the baby into the unit, and really just their key responsibility is just, acclimating them to time and space and really incorporating them into the plan of care, giving them a warm welcome, kind of talking through some resources very lightly, because obviously they're in a little bit of a crisis, a little bit of a shock, especially with a small baby admission. So they've been really helpful. Staff were a little resistant initially. It wasn't the easiest rollout, but we did see through looking at our data and tracking that it does reduce our safe events, because you know what you are responsible for, especially when you have a newer nursing team. And so that way they know who's responsible for fluids, who's responsible for calculating our medications, who's responsible for what job, and it doesn't create any overlap in responsibilities or roles. It also just creates that feeling of I can take a breath because I know what I'm responsible for in this time and space.
Awesome. Anybody else? That's great. Thank you, Heather, for sharing that.
Of course.
Yeah, I love that idea. That's one of the things we struggle with as well. And I think that's a really good way to make sure we try our best not to trade people out. There's sometimes circumstances where someone has to go to a delivery or something, but I think that just is one of those visual things is so simple that can make a big difference.
And for your bouncer, don't you think too, like they'll know, like if they have
Yes.
the role, it'll make it even easier to, minimize any of that, trying to push people one way or the other or gently expel them from the room.
Yeah.
Yeah,
Yes.
Katie, I'm happy to connect with you offline and share how our roles are, kind of what they look like, and show you how we kind of divide up the workflow.
That'd be awesome.
Yeah, that would be excellent. Thank you.
Definitely.
I think most of you are probably in the Small Baby Facebook group that we made for the series during the summer. So I'll take a screenshot of this. Anne, I know you were asking if we could get a copy of that, but we can pull that off if Jane gives permission, and we can, formally put that up there so you guys can take that down from the Facebook group and comment on it. And Heather, if you want to add yours in there, I think you're in that group as well. You can, add a screenshot of yours or add some of the comments. I think those are great ideas. Don't you love having a Q&A call where we can share these
Yes.
things?
I know, and we're only on like slide 4.
Exactly.
And I don't want to rush. So, if we don't get through all the slides, Katie and I know I can speak for Katie. We're happy to get back on and, talk about some of the other things, but it's a huge benefit to us too, to hear, hey, yeah, that's everybody kind of needs that. And then your culture fits it in the unit to what you're going to get the buy-in for. So
awesome.
You can go to the next slide, please.
Sure. Tweet, I saw that you unmuted, but I don't know if it's an accident. So go ahead and raise your hand if you had a question or something. Okay, next slide. We're ready?
Yes, please.
All right, there you go.
I don't see it. Oh, there it is. Okay, so again, this is the update that we made to the initial checklist that we had. You can see that there's a screenshot there, and on the back of our admit checklist, it again reminds everybody what their roles are. Just another reinforcement, and also for the debrief where we remember what everyone was supposed to be doing. So if something wasn't done, we can kind of go back and look at whose job that was, and in a very constructive way say, well, is that the right job for that person? Is it feasible? Are they really able to do that? Or do we need to navigate around that and give that to someone else? So that's the purpose of it here. We became very, very strict with our the end of the year as far as who could be in the room, and in agreement with our neonatologists for our small babies, we do not allow any teaching students or interns within the patient room for the first hour. Now, if we get like a really nice stable 28 and 0, just some CPAP, we might consider letting one of the interns come in with her preceptor, but we've just found that it just gets so out of hand. And right now we're also taking on residents, and sometimes a respiratory therapist has a student, and there can be up to 10 people in the room. And we've just felt like for this next going into 2023, we're going to be very, very strict about who's in the room. And then again, also having that strong RN as the writer or the scribe to assist and redirect us with a strict golden hour timeline. So we want the writer's job. In the past, for me, I remember when I was helping out in writing, I was just like writing things down, not, like I said, not really paying attention, just trying to help the nurse get the charting done. But actually, we have made her one of the most important persons in the room, and we need her to be able to be dedicated to be in the room at least for the first 60 minutes. Because as you'll see on our next slide, throughout the golden hour, we've kind of broken it up into 15-minute, just a quick stop, timeout. Where are we? Are we meeting our goals? Do we need to regroup? For example, if our goal is always to get lines in, that's our first goal, and to get some fluids going within 15 to 30 minutes. At 15 minutes, we do a quick timeout with the NNP or the NEO. How are the lines going? If they haven't got the UV and it doesn't look like they're going to get the UA, then we do a timeout and we decide, okay, do we need to stop this and try a PIV? Because remember what our goal is. We're not making it with the lines, so should we do something else? And this also came from the fact that we had a perfect, beautiful small baby admission, but somewhere along the way, the servo probe came off and no one really noticed because the baby was covered with drapes for the line. And so that baby ended up getting pretty cold. So that's also part of the 15-minute check. You know, is the temp probe still on? Is the baby still stable? How's the SAT looking? Is the CPAP still in the nose? All the things that you can miss when you're trying to get on to the next thing. So next slide. Here's a picture of our special delivery unit. This is one of our pandas in there. We're very lucky to have a delivery unit between two of the ORs. So you can see on the left and right of that picture, those are doors that go into the OR. So after the baby's born, they come directly into our special delivery unit where we have everything we need to stabilize the baby. One of the things that we learned down there that we thought would be really helpful getting upstairs, again, like super strict role definition, make sure if you can, you've done this before you leave, is getting the head circumference before we use the total midliner or before CPAP goes on, getting a length and weight. We need the weight to admit the baby. So if we have a weight, we can give that to our unit secretary right away to get the baby in the computer, put the OG tube in for us, and then bring the baby up. And of course, we do a phone call upstairs to let the admitting nurse know that we're on our way and what kind of respiratory equipment we would need.
And I think,
go ahead.
Yeah, just to point out too, and I had noticed, I think it's Marika, am I saying that correctly? In the chat had mentioned that they wear colored badges for NRP training as well. And I found that to be a really interesting suggestion because I think that's something that then could be a change within our whole women's hospital and potentially then make it easier sort of for our team to accept that as a change in the NICU when it comes to admission time. I really like that when you have time to define the roles prior to a baby being born. You could start out downstairs, or for us, it's downstairs in the labor and delivery unit with really clearly defined roles, because that is another area where we struggle with that a little bit as well. Just making sure they stay clearly defined. And one other thing I wanted to mention too is, as Jane was saying, you know, some things we've had to sort of adapt because of our medical record or, you know, certain admission policies. So like she was saying, we need not only the weight, but we also are required to input a head circumference and a length prior to getting the medications over to pharmacy. And then also, you know, if we have expectation of having radiology up in the unit to be ready to shoot an x-ray, then it's really nice if we have our OG placed downstairs prior to the baby coming up, especially if the baby's placed on CPAP right away, you can start venting that belly immediately. But those are some things we just sort of noticed that there was not a very long time, but just a little bit of lapse in time where we're waiting for respiratory to make sure that the baby's safely on the transport equipment. And that was an opportunity for us to build in those little steps downstairs that made it really easy to then pretty much transfer the baby over to the giraffe and the NICU monitoring, and then go right into the important things like surfactant and lines without a lot of interruption and tasks that have to be done upon admission to the NICU.
Thanks, Katie. Yeah, so that's the reason that we, you know, went back and even defined the roles even more is because the neonatologists had made a commitment just recently, a couple of months ago. They've always been committed, but an extra, you know, push for our small baby program, in that they wanted to be, their priority was lines and surfactant. We give surfactant on all our babies less than 28 weeks. So what was happening, it was like the first 15 minutes, the admission nurse was kind of like getting a length, putting the OG tube, putting the leads on, all of that kind of thing. And we wanted to eliminate that as much as possible. So as soon as the baby hits the bed, we get the servo probe on. If the baby's stable, then the neonatologist decides, am I going to go for Survanta first, because we also do Lisa now, or lines first. And we have that quick discussion. And then those are the two priorities that we're trying to get done as quickly as possible. Next slide, please.
Yeah, Jane, can you, as I'm doing that, can you clarify when you start using your total midliner? Someone asked, do you use it during golden hour or when in the process? I think you said it, but maybe just to clarify.
No problem. We put it on all babies in the SDU, and it stays on them for the first week of life. not
they're
all
pretty
babies.
much laid directly on it upon birth, being placed on the warmer.
Less than 32 weeks, right, Katie?
Yes.
Does that answer the question, Kathy?
Yeah, I think so. Connie?
Great. And here's a prenatal info checklist that we also created. And it's funny because you're like, oh my gosh, how many checklists can we have here? But believe it or not, the team loves the checklist. They just feel like it's just, I think where a lot of us nurses are task oriented and we like to know that we've done what we need to do to get ready for this baby. So we've revised this checklist so many times just to reflect the things that we think are super important. But the feedback that we've gotten from the team has been great about all of these checklists. And it's also a very helpful for your newer small baby nurse, a very helpful conversation kind of multidisciplinary rounds tool that you can bring to two rounds to talk about, hey, on the prenatal info sheet, I looked this up, I know this is important, and I want to share it. So in the perfect world, this will get filled out before the baby comes upstairs, because we are very lucky to have a dedicated small baby team. So if you're getting a small baby, you're one-to-one with that baby on admission in a perfect world and in the first 72 hours of life. So it isn't too much to ask that nurse to make sure she gets all the prenatal info that she can. And based on this and some observations is how we ended up doing the placental work that I think is coming up on the next slide or soon. And we also implemented this with COVID because we found, I don't know if you guys have seen it, but a lot of coagulopathies in moms with COVID and some weird stuff with the baby. So that was also a good history. And these are histories we felt were really important as a bedside nurse to know. Next slide. And this is our timeout huddles that I referred to in the beginning. So like what I said, we would bring a baby upstairs, begin the golden hour, and then the next time we all talked about anything in a kind of role model form was during the debrief. But what we found out was things don't always go perfectly. Like I said, maybe respiratory forgot to warm the Cervanta. Maybe the camera for Lisa is, downstairs somewhere, and we have to regroup and reframe the order in which we're going to do things. So once the baby gets upstairs, as they're being admitted to the isolette, the role of the neonatologist is to call a timeout. It's just very quick, and you can see it on our checklist. And at that point, they say, here's my plan. This is what I want to do first. This is what I want to do second. It's either going to be lines or it's going to be surfactant. And then we have that completely, in a perfect world, ready to go. So that's what initiated having the line trays set up before the neo got upstairs. Because if they want to do lines first, basically, they just have to put on their gloves, place the lines, and hopefully that goes very smoothly. And then at 30 minutes of life, we take a break. And we ask, how's it going? Are the lines in? Are we struggling with the line? Is radiology tied up across the street? Is this a point where we're going to think about maybe needing to do a PIV for the baby? And then again, at 60 minutes, we have another timeout just to make sure things are still on track. Temp is okay for baby. And then finally at the end, when we do the debrief. And I think this has probably been one of the most important things that we've done, because it truly engages the scribe to be looking around the room. And at 15 minutes, still 10 people in the room, we need to stop and get those people out of the room. And if we need to read, who all, as you guys know, have their own little way that they kind of like doing things. Some people like to do lines first. Some people like to do Cervanta first. So we widened the goal to say we want all these things done in 60 to 90 minutes. The order is sometimes preferential based on what the baby's looking like in our neo. So this was just kind of a way to make the golden hour a little bit more individualized, but still meeting the same metrics. So I think it's been a really great win for our neos too.
And Jane, can you speak to your golden hour kind of, I know in the beginning, and if people watch some of your older presentations, you had ended up extending that 60 minutes to 75 or 90 minutes. Have you still found your golden hour is arrival to the NICU? I just want to clarify that too.
Yes, thank you so much. So it's almost 20 minutes before we get upstairs with the baby. So we allow like a full 90 minutes for the golden hour.
Great. Thanks.
Some of our goals are still to be within the hour, like initiation of glucose and surfactant. Yes. It's kind of just that top-down goal is usually by 90 minutes, and that's largely dependent most of the time on radiology clarifying line placement and certain other things. We found that if we were putting the top down and having to reopen it, we had a lot more temp instability than if we just waited until the baby was fully ready to put the top down. So, but we still have the push for glucose infusion, surfactant within the first 90 minutes, and ideally the first antibiotic as well.
Great, thanks for clarifying. Anybody have any questions about this so far? I'm not sure it's on the next slide, but okay. There you go.
Okay, next slide. Oh, and these are just some clarifications that we had for our own team. And I just put this slide up here to help you guys see what our true goals are, kind of answering the question that you just asked, Kathy. So we know that it's not easy to make this happen. We know we have to practice. And we also wanted to remind our team, don't forget that these are our goals. It's very helpful, I think, for people to know, like, okay, what do you guys really want here? Like, there's all these different parts of the golden hour. What matters the most? And we went over this with our neos, and what matters the most is keeping the baby's temperature. We all know that's low-hanging fruit, but it's a huge variable in outcomes. So if we can get the baby upstairs warm and keep them warm, and that is very closely being monitored. And that's hard to do because you guys know there's a lot of hands on the baby, which we're also trying to make a change. Really, there should only be one set of hands on the baby, and that's the admit nurse on the baby. But when 3 or 4 people try to get in there and one person's doing the chem and one person's putting the leads on, all of that is losing temperature. I know if you guys have seen the giraffe presentation where the educator shows you like the change in temperature for a baby every time you put your cold gloved hands on them. And then we want glucose infusing within an hour. And that's, like I said, at 30 minutes. If the neo is struggling with lines, then we will take a timeout and decide how we're going to achieve that goal. The surfactant, same thing. And then again, back to the communication. And those are the stopping points for communication. So on admission, we have a let's plan what we're going to do huddle. At 30 minutes, we see, are we being successful with that plan, or do we need to make a change? And then the 1 hour, the timeout huddles. Next slide.
There's been a couple of really good questions too. Did you want me to answer those now?
Yeah, thanks,
okay.
Katie.
So there's a question from Donna. Do you have a goal of getting antibiotics on board during the first hour of admission? That's definitely our goal. And ideally, we'd love to get to a place where we can achieve all of this within 60 minutes. So we're definitely pushing for that. But we do try, blood cultures are pulled right off the lines. And then we do try to at least get the ampicillin going prior to 1 hour. That's one of those things we have on override in our unit. Our gentamicin is premixed, so we have to wait for pharmacy to send that over, but ampicillin is readily available to us. So we have made it a goal of at least trying to get that started by 1 hour. It's, beyond, the glucose and the surfactant are priority, but that is something that we strive for. And then I saw someone mentioned that they admit their babies directly into the giraffe isolate from the delivery room. And that's definitely something we've discussed and will continue discussing. For us, it's just kind of been an issue of space in the SDU. We don't really have the space to keep one down there all the time, but we've definitely talked about rolling one in when we have an extra fragile baby and moving them upstairs. We kind of have a little bit of a hike up to our NICU. And we found we use the shuttle and the giraffe for a lot of transports to and from Children's Hospital and things like that. And we find it to be very difficult to move that without jostling the baby as much. We found that the Panda by itself having all of the things it needs right directly on it. We found that the baby jostled a lot less, moving in and out of the hallways, in and out of the elevator. So just, it's kind of been the logistics. I think admitting directly into a giraffe is a fantastic idea. And it's definitely not off the table for us. We've discussed it at length. It's just a matter of kind of trying to decide what's the best for our space and moving the baby. But we do have a very delicate, we used to have Panda and then Transporter and then Giraffe. We've eliminated that. We now move them on the Panda. So we're working towards the least amount of movement as possible. And then there's one more question here. Do we wait until they get back to the unit to administer surfactant? And that is, I would say, most of the time, but we do have a couple of NEOs who have indicated that if they feel like their tube placement, they're very secure with that downstairs, and we have actually administered surfactant right in the delivery room. So again, that's part of that pre-flight checklist where we can discuss that. And if they do want that, that's something we would have to bring down from the unit and try and get it a little warmed up. So that takes time and planning. So we're certainly open to that. It just kind of depends on the neonatologist preference, and we try and make that happen if they're okay with doing that.
Awesome. I think you got them all, Katie.
Nice going, Katie. See, everyone needs a Katie, I'm telling you. Next, and this is just a quick snapshot of the first part of our checklist, and you can see the highlighted areas. Those are highlighted because those are the metrics. So when I collect this, I can quickly see the initial temperature. And again, this is something that the scribe would have with her, and she will be going through this as she's doing the admission and making sure that all these steps are being followed. I won't take too much more time on this because it's, and then again, more metrics. And like I said, we can share this with you guys. We learned so much when we had the giraffe rep come and talk to us about how the giraffe works, especially related to humidity. I would highly recommend anybody kind of use that and do that. We were having a lot of high sodiums initially on our small babies. And then we learned about using kind of like the Neo wrap. If you put the top down, and you have to pop the top before your bed has reached the humidity that you've set, it's best to cover the baby again with some plastic or Neo wrap, so at least they don't lose all that water loss while they're being, again, exposed to room air. So these are just more of our goals. Next slide. Again, more things that we're thinking about. We are always trying to prevent early onset and late onset sepsis. So we try very hard not to do any skin punctures on these small babies in the first 3 days of life if we can. Next slide. And I don't know, Kathy, if you want me to talk about this or just go to questions, because it's 11:52. And these are the last couple of things that I had to talk about us using the placenta to get a blood culture. So you just let me know based on the chat and questions how you'd like to go from here.
I think just maybe comment to, when you started, and maybe we can have a follow-up on this as well.
Sure. Okay. So what we started noticing is, like with everyone else, we're working very hard on antibiotic stewardship. Just prematurity alone is a risk factor for infection. So most of our small babies would go blood culture from their umbilical, from the UHC. We'd send that to lab, but that's a very small sample. And then we would put them on antibiotics for the first 48 hours. If nothing grew, we would DC the antibiotics. But what we found with 2 or 3 babies is that on day 5 or 6, they ended up having sepsis. They were growing an organism, and we just couldn't figure out why that was happening. So we wanted to find out. I mean, usually that early, it's probably linked to maternal, and perhaps we just didn't get enough of a sample from our UAC when we sent it to lab. But then we were having these kids with what was being called like a late onset sepsis, but probably was something that was brewing when baby was born, and perhaps we masked it with antibiotics. And then, it comes back with a vengeance 3 or 4 days later. So in order to mitigate that and to try to give us one other piece of information when we're deciding if we're going to stop at 48 hours. So again, just one other piece of information. We're also looking at how the baby looks clinically, CBC, platelet count, all of those things. We just started this a couple of months ago in collaboration with Labor and Delivery for all our small babies, which for us is less than 28 weeks and less than 1,000 grams. We send the placenta for pathology. So for just a look, how does it look? We send it's also microscope and let us know if it looks like choreo. And then the newest thing that we've done is the labor and delivery nurses draw a blood culture from the placenta, from the cord. And we have a great relationship with our lab, and they will do that as quickly as possible for us. And then within about 48 to 72 hours, just about the time we're thinking of discontinuing antibiotics, we'll get a call from them and they'll let us know if anything's growing and or if they feel like it was a very suspicious looking placenta on pathology, and it definitely was choreo. Sometimes, and in quite a few situations now, we've extended the antibiotics out. So this is a paper that Katie made, just helping everybody, kind of like a quick guide on what do you do with the placental blood when you bring it upstairs. That's what that is.
Great.
I know I did that really quick, and I'm happy to talk more about it in another presentation, Kathy, but
sure.
I think it's been very helpful for us to, and this was the one of the infographic that we made for labor and delivery. And I love what Katie did. So she kind of put a picture in the corner that shows the tiny hand and the vein that we're looking at when we try to draw a culture. If we can't get it from a UAC. And, these girls downstairs on some of the placentas, they can get 3, 4, 5 mLs. Sometimes they can't, but that's a much better sampling for a culture than the tiny bit of blood that we send on our kids from admission. And again, it's one less pullback on the line, one less risk for hypertension when you're moving things around like that. And I would imagine a lot of places are already doing this. And I think some places actually are getting their CBC also. So that's a goal of ours in the future. But these are our kind of major updates and things that we've done since we started. And again, this is another picture of the back of our admit checklist with the debrief, how you can see very clearly to the right to make the debrief more efficient in case everybody just standing around going, what do you think? How did it go? We have very specific questions to the right, so it makes it even more efficient. And those are the things that we can actually make process changes to. Thank you guys for your time. I know that I was talking fast. It always happens like that, but Katie and I are always available to answer any questions on another Q&A. And so we've already introduced ourselves.
Thank you again so much for always just sharing your journey and just the practical day-to-day tips of what you've done for your program. So we do have a few minutes. So if anybody has any burning questions and you want to raise your hand or put them in the chat, or again, keep the conversation going in our Facebook group. If people are going to ask, where do I see the replay and can I share this? And the answer is always yes. We'll send out the email later where people can rewatch this and share it. And if you registered for this, you should be able to go straight to the replay page. So, which if you were here, you probably registered. So, but I'll send out an email so that you guys have that direct link.
There are a couple more good questions in the chat.
Go for it, Katie.
Here.
Yeah.
So Anne asked, she mentioned that her NEO thought there could be a lot of contamination from placenta blood draws, and have we seen this? So like Jane said, that process for us is still relatively new, so we kind of have a smaller sample size. We have not had any contaminated placental blood cultures yet. We had kind of a rather rocky story earlier in the week of a baby who was born in a very remote ER, and somehow the placenta made it to us in a suction canister. And so that would be a placenta we didn't draw blood cultures off of, but we still sent for pathology. I think the NEOs, as we gather information about the blood cultures, and we're just kind of watching those, are really, really watching the placental pathology the most, making most of their decisions off of those. But in the meantime, we have not had any contaminated blood culture specimens. That's kind of why we're doing the whole workup, because I could see where you might also have maybe some contamination with the swab culture or something like that. And then I know, this is a project we've been wanting to start for a long time, so it did take some convincing as well. And there was quite a bit of literature out there, so I'm not sure what the contamination rate might be in places that have been doing this for a while. It would be good to look at that information. And then Latoya asked about, going up. So Nadia asked, when you say placing the OG, is that referring to Lisa? So actually, that's referring to just an orogastric tube for venting. When we're talking about placing an OG in the delivery room. And the main point of that is we like to do X-ray confirmation of our OG tubes. That's how we verify placement. And if the baby comes upstairs and we've got an X-ray available immediately, because some of our neos like to see that first film before surfing a baby, then we like to know that the OG is already there, and that's not something that's going to slow things down. Now, if the baby's all ready for transport, respiratory is ready to go, and the OG is the only thing left to do, we wouldn't necessarily hold downstairs just to complete that. Those were just things we thought, hey, the nurse can be doing this while RT is just sort of making sure that the transport equipment is all ready to go. So it's just kind of making sure we weren't wasting any time that we had with the baby downstairs to get things ready for upstairs. The catheter for Lisa is placed by our physician at the time of surfing.
Thank you.
And our NICU also started Lisa recently. I see Lauren mentioned that. That's a new process for us as well, and it's gone very well. So it's hopefully it'll be something great for your NICU as well.
Yeah, I will say it is time consuming. I really didn't realize it, and a lot of our neos are pretty good at it now. But man, by the time you get the camera, the visualization, you get it will cut into your golden hour for sure. So I think that sometimes they'll do lines first and then Lisa. Of course, if the baby's intubated, they usually go for the Cervanta first and then the lines, because of course that's going to go much more smoothly.
Yeah, and I think it's important to note too, you're always trying to balance with a small baby. You want to be intentional about the steps you're taking, and you want to be as efficient as possible, but you also don't want to be doing 2 or 3 things to a small baby at the same time. So, if you lose minutes or a little bit of time at the end, but you've had to kind of sort of take a break because that's what the baby needed, and that's okay too. A lot of it's just been kind of reminding our team, like, there is some grace with this process. You have to watch your baby as well and make sure you're not sacrificing intentional care for just trying to do things quickly. So.
And you don't want it to be a frenzied pace. It really should be run like a code. That's kind of how we talk to our team about it. You do a code, everybody knows what they have to do. The same thing with that, completing the communication loop. We actually say, is your servoprobe on? The servoprobe is on. Check. Done. So that's why it's really important to limit the talking in the room. That it basically, like I said, it's a trauma. Katie came up with that, and I love that admitting a small baby is like getting a trauma in the ER. And so we should be treating it that way. And that's kind of how we're making some progress with administration about getting radiology to us in a much more effective and efficient way. There were times when we had to wait over an hour for radiology, and for the neos that weren't confident with their lines, they didn't want to use that. So that meant starting a PIB just because we couldn't confirm line placement. So recently we had a meeting with administration and with radiology, explained this to them, and they were super responsive, and they were like, we get it. But sometimes I think to other people, it's just another admission, but it's not. It's a small baby alert, which we're kind of calling it, so that pharmacy is also aware, hey, there's a small baby in the NICU. They're going to need their amp. They're going to need their gent. And when you think about it, for us, we probably get 5 to 8 of these babies a month. So that isn't too much to ask when you have an alert, I think, to ask departments to just kind of drop what they're doing and focus on this small baby.
Yeah, and actually one thing we would love to reach out for feedback as well would be just the admission process and sort of what you use for your EMR. One thing that we've kind of gone in circles about is just, if this department requires an order, if you back things up, not everything happens in a perfect timeline. So maybe mom wasn't even admitted, just came in and delivered, and then you're trying to admit baby from mom's chart, but she's not admitted. There could be so many delays for just an electronic piece that shouldn't really be causing a delay. And sometimes we have to pull things from, the Pyxis in a way that we're maybe not supposed to do, or we've had to work around. So that's one thing we've tried to impress, like, do we need to admit these babies as a trauma? Or, something when you see a trauma alert in the hospital, everybody that looks at that chart knows that's a trauma. So if you guys have great ideas on how to achieve sort of some of those little technical things that can slow stuff down, we would love to hear it. We've had the idea of maybe pre-admitting the babies, but then you don't know, the gender yet, you don't know certain things. So that's one of the things that we're still sort of striving for, what's going to be the best answer there.
Yeah. As nurses, we're really good at the workarounds. We still get what we want, but it's not in the perfect way. And I'm really discouraging us continuing the workarounds just because we shouldn't have to do that. That's not the best process. And these traumas, they're not working around a trauma coming into the ER. I know that for sure. So
I love that idea to escalate or to flag. And I think you're right, that 5 to 8. I mean, would they say don't call the trauma team, every day we have a trauma come in? No. Yeah. So I think you're right in that. I love that. I put in the chat for, here at Synapse, we love you to take this information and not just say like, that's a good idea, but to really implement something or to start a conversation in your unit around what you would do. So I would invite you in the chat to say one thing that you learned today or that inspired you so that you could go back to your NICU and, do something with this information. Is there a part of this process? I saw a lot of you saying the debrief. And I think that Jane and Katie and Dr. Eldridge and Dr. Vargas in the past, if you even think about their, maybe baby checklist and that communication, I think one of the things that your team really excels at is communication with your team. I know that those things that you've put in place are because there were deficiencies that you fixed, but I think that debrief, those timeouts, those are so easy. They're easy to do and easy not to do, but what a difference they make in your consistency, people being heard. And I know that really contributes, to your unit's morale and your unit's engagement when you have really pushed on this, over the years. And I see Shannon too. So Shannon, you have something you would like to add? But I see you're getting chatty now, so I love it.
No, I love it. I love all the checklists. I was just thinking, like, could you incorporate some of the pre-admission, like is there a way to incorporate into a report in your EHR, just to make it a little, like, one less checklist to fill out? Because I know I love a good checklist, but I know I annoy people with the amount of checklists I want them to do, or things I want them to fill out. Is there a way to make some of that, if mom is inpatient, obviously, a report, so it's just a little easier to pull that? But I think it's amazing. I love the work. I love the, lining it up with, Top Gun Maverick and inspiring your team, and then you got to make this fun.
Yeah, they really
did a good job doing it.
I know. Yeah, and I'll say, like, one of the things we've had to balance is our checklist itself. The one checklist was starting to get so wordy. And, we had a couple in the beginning where there were, and I'll reiterate again, it wasn't a lot of new processes. It was a lot of things that we already did, just kind of all put in one place. And then we had a couple, simple errors that wouldn't probably normally have been done on an admission. So that we had to take a step back. Is this too much? Do we need to simplify? But we seem to have two different camps in our unit. Some people that just want everything to be spelled out, and then some people that just want to know, what are your basic goals, and then let me build around that. So we offer several different checklists, as you've seen, but then we're also trying to just reiterate, and that was one of the points of making this slide set for our team, was just, these are the basic things that we want. Not a lot of this is new. Try to review it before the admission as you can, and just focus on those those top goals. And then also, we're planning to present this to our whole staff as well. We've had the staff, the small baby classes, and we do have a dedicated small baby team. We want the whole team adjacent to that to be well aware, because they're certainly involved in the process. And they're definitely around when these things are happening. So we want to make sure we're including everyone in that as well. But yeah, I think putting it in the EMR is a great idea because then that adds weight to it too. I feel like people think it's the more official thing that you need to get done if it's in a computer.
Totally.
Yeah. I just was seeing, Nicole, you're saying that you love the checklists and the timeouts and you're having issues with x-ray. And I think that's where these audits and these checklists have come in to really help. Katie and Jane, I don't want to speak for you, but I think I've heard you talk about this, is just having the data to share back. So we're not getting it until 47 minutes. We're not getting it until 62 minutes, like being able to track the trend and it's not then like, I tried and I called, it's not the I part. It's like here's our system problem, like you said, and do that. So, I saw you're on video now too.
Kathy, to that, I was just going to say, with the radiology, it was just craziness, like unacceptable. The data, it's just data. I always try to tell people it's a people problem, it's a process. So that's all we're talking about, is just a process problem. And these small babies, it was up to an hour and a half, sometimes 2. So I went to our administrator and said, look, if you want a small baby program, we need radiology to be here at least within an hour. And, they went to this level that I can't go to. And we had a nice Teams call with the director of radiology, who thought for sure that they were always there before an hour. But she was very much on board, went through her data, got back to us next week and said, whoops, really not making our metrics. We're not getting to NICU within an hour. And we're going to have a team meeting. We're going to talk about this. And I mean, it's just real more about, just have to be careful with that people versus process thing. So where people feel defensive and it's the radiology tech that's not getting over there. It's just more about, here's our numbers, look at your numbers. And it was a great conversation. So departments are not aware of what NICU, what happens in NICU, why periods are so critical. I think people get it in the ER, but not so much NICU. And once I explained that to the radiology director, I'm having a team meeting. We'll get those, we're going to prioritize these babies. And it was great. It's time consuming to get the data, time consuming to have the meeting. But I feel like it's definitely worthwhile.
Awesome. Nicole, did you have anything you want to add? You can unmute for a sec. And while you're doing that, Nadia asked a question about what if you don't have a small baby nurse from your team on shift? How do you staff for that? And, what's the crossover with your cooling program? And you want to talk a little bit about that, and then that'll be our last question.
Yeah, I can address that question. So that's a great question. And as a charge, that's something that we look at and we try and always make sure there are enough people, but we certainly at times where there's multiple small babies in the unit, multiple cooling babies. Often there's crossover with our nurses to go to delivery and do picks. So it's always something you're trying to work out. And that's one of the main reasons we want to put this information out to the staff too and update them regularly in our just normal staff meetings. I think one thing that can happen when you build a dedicated team is there can be some divisiveness in the unit. And we didn't want that to happen. We want everybody to feel a part of it. But we have had times where that's just not possible. And I think what Jane touched on earlier is how we've had to adjust the admitting RN versus the writer or the baby bouncer role. What we previously thought it was most important to have the admission RN be the one stable person in the room who was the strong nurse who understood the small baby tasks and all of that. We actually realized it's more important to have a stable person be the writer and have your strong RN. So if there's ever a time when we don't have a small baby nurse that can come help out, we certainly have a lot of nurses that aren't technically small baby nurses, but have spent a lot of time doing neuro-appropriate care and know how to care for small babies. So we might make them the admission nurse and have our charge nurse be the writer, baby bouncer as much as possible. And that way they can say, okay, this is your next task. This is your next task. They're the ones looking at that overwhelming, sometimes checklist and just kind of prompting that person, here's what we're doing next. And I think the timeouts help too, because there's no secrets. There's no, I don't know the process. It's the doctor coming right in the room and saying, this is what we're going to do. This is the order. If it doesn't work out, we'll try this. And so everyone's aware of the plan. And the tasks themselves, taking a temperature, placing a servo probe, it's nothing that requires a strong amount of skill. So that's where we really have started to learn that that writer role is so crucial, perhaps even more so than even the admission nurse role. But yeah, there's certainly been times, and that's where we just try and pull a charge nurse as much as possible to dedicate themselves to that bedside.
And I think that you guys have set it up so well with the checklist and all of the support you have, and you know, your neonatology team on board and all of that, that if you don't have a small baby nurse, you have the, you know, you have the means to make it happen. Even without that specific person who has that training. You know, we're all NICU nurses, we know similar goals, and yes, there's additional training, but I do feel like, you know, there's some of this that it's all ingrained in our basic NICU knowledge. So having those checklists, those supports, like I said, I love a good checklist. It makes it so that anybody can walk in, see where you are in the process, and continue. And I read an article in like an NRP instructor update years ago that said the recorder is the person that the job, the role that gets forgotten the most and assigned to people who are unskilled, or, you know, like it's the last thought, when really it's the most important role, because they are the ones, especially in places where, you know, in PICU and PALS, we have a lot of providers who step back and lead the code. And that's not always my experience as a delivery nurse. You know, we have one neonatologist in there. We have an extra person maybe if we ask for it, but you know, they're the intubator, they're the line placer, they're also the leader often. And so having that person to record to say, it's been this many times, this, you know, this many minutes since we've done this, or it's time for us to take a time out. I just think it's brilliant. I love the use of that.
Yeah, I always tell my interns, if you want to learn the most about running a code, be the writer, because you get an ideal vantage point. You can see, and then you can actually say like, oh, 3 minutes is a long time, or, you know, you learn so much just standing back and watching, and for sure. And yeah, I mean, and just to be transparent, I mean, we have staffing issues, we have those things, you know, that everyone else deals with. We can't always guarantee that our person that's standing at the door writing is going to be the same person the whole time. We just make that our goal. And then, you know, we're very lucky that our other departments, our physicians are very compassionate to the fact that things aren't always going to look ideal as far as staffing goes and personnel. But everybody there is trying, you know, their very best, and we have everything in place to try and make it a success. And, you know, most of our nurses that aren't small baby nurses are our newer nurses that want to eventually do that. So it's a good opportunity for them to learn as well.
I love it. All of it. Thank you, everybody, for being here. I love it. Oh, Amanda, thanks for being here. Amanda's one of their respiratory therapists. She's one of from the team. She's given some great presentations, you know, on our community calls in the past. So thanks, Amanda, for hopping on and to support your team here, and for all that you do for developmental care. I guess just happy holidays. Thanks, Shannon, for having your Christmas tree up. We love that. And this is our last call of 2022. I can't believe it. And we'll be back next year, of course, with more Q&As in January, as well as some additional maybe follow-ups from Jane and Katie and team on some of their placenta work and antibiotic stewardship, which is always an important conversation. So, you know, thanks everybody for being a part of the community, and we wish you all the best over the holidays and into the new year, and we'll see you in 2023.
Oh.